Hello, everyone. The first topic to kickstart the teaching from today for the new batch is on airway management. And I know you've had a practical session. So this is going to be just a little more detailed in terms of how we manage pediatric airways. And I must apologize because the slides have been piled up together last minute, and I'm extremely grateful to Rosalie Campbell, who probably you don't know, but she was one of our colleagues, and she's still doing pediatric anesthesia, but she doesn't do PICU anymore. So majority of the slides are hers, and I so wish she was talking to you about pediatric airway management rather than me, because she's clearly more of an expert. But here we go. So it's a procedure that we do, not infrequently, but I think it's just important for us to acknowledge, and most of us here are pediatricians, that children, one, are not just small, two, but there is a developmental trajectory in both the anatomy and physiology across the age range. So starting from neonates into infancy, into childhood, and then almost taking an adult size. And the biggest issue is they have small nares and small airways, and they've got a large tongue. So tongue is the major reason for obstruction whenever we're talking about an obstructed airway or difficulty in breathing. And since they're obligate nasal breathers, despite having partial nasal obstruction, they still try to breathe through the nose. And that causes problems. Especially the younger infants have larger occipits. So that makes it difficult to position their airways into an open position. And they also have a U-shaped epiglottis, so it is sometimes very difficult to get a proper view. As you can see, as the child matures, the shape and the actual thickness of the epiglottis changes, and by the time you probably reach about the age of 8 years, this is what the view would be. So it is much easier than otherwise. And of course, as we know that the smaller the tube size, the higher the resistance, because it's related to the radius to the power 4. But if there is turbulent airflow, which would happen every time you've got an obstruction or you're finding it difficult to breathe, the resistance goes up by the power 5. So if radius is halved, the resistance goes up by 16 times. And if the airflow is turbulent, that goes up by 32 times. So this just makes things harder for a small child.
So what do you mean by turbulent airflow?
It's just like, if I'm breathing nice and slow, it's different. But when I'm agitated and I have got some kind of an obstruction, the airflow would not be as smooth as otherwise it would be. Okay. And so I'll just briefly talk about the anatomical and the physiological differences that make it important for us to be aware of how a simple situation can become complex if you're not careful. So the larynx shape is very different. And as you can see very clearly in this picture, the infants have a funnel-shaped larynx. So the underdeveloped cricoid is the narrowest part. That both makes the airway small, but also if we have a tight-fitting ET tube, the edema and trouble upon extubation following from that. And we do use steroids pre-extubation more frequently in younger children than in older children, but we would always assess, depending on how long they have been intubated, whether there is any leak, etc., before we decide whether we give pre-extubation steroids. And then, of course, the cricoid develops fully by the age of 10 to 12 years. This, as I already alluded to, the effects of edema or any kind of airway obstruction is much greater because a normal infantile airway radius is only 4 millimeters. And if you have an edema, that would lead to only a 1 millimeter radius. And then, of course, the cross-sectional area reduces by 75%, but the resistance goes up by 16 times. Whilst in an adult, in comparison, the cross-sectional area would only reduce by 44%, and the resistance would go up by 3 times. So there's a huge difference. They, of course, have poor oxygen reserve and high consumption. So clearly, it's very easy for them to become hypoxic and de-recruit, as well as we have much shorter time in trying to get an tube in the larynx before they start decompensating into bradycardia, hypoxia, and cardiac arrest. So we have to be extremely careful when we are intubating that we have time-limited attempts at intubation, and if we fail, we go back to oxygenating the child. And of course, the chest wall is very compliant because the cartilage hasn't stiffened well. The thoracic musculature is weak and the diaphragm is weak. And I think I cannot emphasize this enough, but when we are bagging our children, they can very easily have a massive stomach because of the air going into the stomach while we are bagging them. And that could cause significant respiratory difficulty. So decompressing the stomach is an important element. And every time we're having to bag valve mask our patients, we should be careful and try to put an NG tube and decompress the stomach. So always think about that. This is a small syringe, but we always use a large syringe so that we can suck out quite easily. So how do we rescue an airway? Well, of course, simple things first. We first see whether the airway is patent, whether we can position the child better. And normally a conscious child would be able to position themselves in a situation which is best for their airway opening. So we try to leave them alone until we are preparing to take control if that's what we needed to do. If the airway is patent, there could be various other indications. And I've tried to keep it very focused on the airway management, and I'm sure you all probably know the indications of why we would try to intubate a patient, and there could be multiple, not just airway obstruction. Well, if it is an airway obstruction, we are looking at having anesthetic help if we have time, possibly sending the child to theatre. But a more straightforward indication, like somebody's got chest infection and they have impending respiratory failure, you feel that they would tire out, or they've got hemodynamic failure with septic shock, etc., like this child we have on the ward now, or a neurological indication. So there can be multiple indications. But first thing first, we look at airway patency, and if the child is conscious, let them maintain their airway themselves. If they can't, then we use the maneuvers. And as you can see, the position of the head, which is neutral or best for airway patency, differs depending upon the age group. So in infants, it's probably a neutral position, so just a thin roll under their shoulders. In a small child, a sniffing position, and in an older patient, a full neck extension is what works. Of course, suction nose and oropharynx, if that is full of secretions, because that could open the air going in and out. We, as I said, optimize the head position, and then start looking at head tilt, chin lift maneuvers, and jaw thrusts. Jaw thrusts specifically in patients where we are worried about C-spine, and we have to keep the C-spine protected because you can't tilt the head in those children, especially the head injury or the trauma patients, till we have cleared this. And then, of course, we start looking at using the airway adjuncts, both the nasopharyngeal and the oropharyngeal airways. We also look at having the right kind of suction supply. So Yanker suction is the best when we're looking at oral suctioning. And if we're going into the nasopharynx, we've got different sizes of suction catheters. Depending on, again, the patient's age, probably for neonates, 5 to 6 French catheter, for infant 6 to 8 French catheter, and for older kids, a 10 French catheter is what we are looking to use. So talking a little bit about oropharyngeal airways, and I hope this is all fairly basic, but I've tried to focus it on basic because I think the PANDA session tomorrow has got video laryngoscopes and other bits and pieces. So oropharyngeal airway as a principle should only be used in an unconscious patient. Otherwise, it can elicit a gag reflex and can make it much worse for the patient. Could cause vomiting, which could make it harder for us to intubate and lead to aspiration. So not for children who are conscious. And it helps by holding the tongue and the soft hypopharyngeal structure away from the posterior pharynx. And then the sizing of it, both the oral and the nasopharyngeal airway, is extremely crucial, so that it's neither too short nor too long, because either of those would actually hamper the airway and make it harder to open it. And we measure it from the angle of the mouth to the tragus, and that's how we would put it inside. And it helps in suctioning the airway if we need it to, but should never be taped in place. Nasopharyngeal airways, on the other hand, can be inserted in children who are conscious. You'd sometimes see children on the ward, especially after an ENT procedure, or those who've got very floppy airways with nasopharyngeal airways sitting on the ward. Sometimes the children post-coenal atresia repair would come back with a nasopharyngeal airway, which would be sutured into their nares, and we'll have them here.
Into the nares.
So that they can't pull it out. It's as a splint because they have tried to dilate the coenal atresia. So it acts as a splint to keep it open. And we can either use a soft ET tube, which can be cut according to the size of the patient, or there are soft pre-made plastic nasopharyngeal airways that are available. And again, the sizing is from the side of the nose to the tragus. Again, extremely important to size it appropriately. And this requires frequent suctioning. And you might be called to the wards to see a patient who's got a nasopharyngeal airway which is blocked because people have been too worried about taking it out, and it might not have been suctioned as properly as it should, or as frequently as it is required. It's a simple process to insert it. So if you feel it is blocked, it should be taken out. But this, I'm talking about children who are not peri-intubation. So we're talking about this, trying to support the airway in children who have an impending respiratory failure, or those who look like they will imminently require intubation. Sometimes we'd use it for children post-extubation, just to improve the airway patency, or use nasal CPAP through the nasopharyngeal airway. And it does help to splint the soft tissue in the oropharynx. And it would also help in suctioning, because that's easier in children, especially the neurodisabled children who have got poor swallow. So this can work quite well. Of course, contraindicated in children, we suspect basilar skull fracture, those who have CSF leaks or coagulopathy, and that would stand true even for nasal tubes. And then, of course, once we've ensured that the airway is patent, we're looking at bag mask ventilation if the child cannot breathe for themselves or need supporting. And we're trying to basically adequately oxygenate and ventilate the child until we can get definitive airway. This can be as effective as ventilation through the endotracheal tube. And this actually is probably the most important skill we should all know, because if we are in a situation where we can't get the tube in, or the child has got any kind of anticipated difficult airway, so long as we can oxygenate the child, doesn't matter whether the child has a tube or not. So it's extremely, extremely important for us to not be fixated on a definitive airway, specifically when we don't have the right equipment or the right personnel around, and it's always important to keep oxygenating them. Well, that's an ambu bag I have put there. On intensive care here, we prefer to use a bagging circuit rather than an ambu bag. And these are the two common types of bagging circuits we use. Sorry, Riaz, just very quickly, I've asked Claire to bring that child in. Yeah, because they're still not sure when they want to take him to theatre, but I told them to go and speed it up. So these are the two kind of bagging circuits which we use. This is the IST piece and the Mapleson's circuit, and they come in different sizes. So 500 ml is the smallest capacity, 1 liter is the default, which is this one, and then the 2 liters is the adult sized circuit. The advantage of using these is that you can deliver PEEP, unlike the ambu bag, because ambu bag does not deliver PEEP. And in this bagging circuit, we deliver PEEP by holding the bag in a certain manner. And you could titrate the amount of volume you're delivering by blocking half of the bag, half of the bagging circuit. Whilst in the bigger bag, there is a PEEP valve, and you can rotate it. The screen valve here at the top, you can rotate to increase or decrease the amount of PEEP you're delivering to the patient. And they are extremely useful, and they do need a little bit of practice in being able to use these bags. Majority of the times in our population, we could use one-hand technique, but in an older child, we sometimes need to use two hands, especially when you're using the 2-liter bag, in which case, if you're using a mask, then you need somebody to hold the mask and somebody else to. If you're holding the airway, then you hold the mask on the patient's face and somebody else bags the patient. So this is what we would do. And of course, the sizing of the mask, I haven't gone through in detail, but something that covers the nose and the mouth, both. Ideally, not something which is too big and covers the eyes or slips under the chin. So it should be a well-fitting mask, and there are various different sizes available. I think we are pampered slightly in intensive care because our nurses would keep patients appropriate sized mask on their bed space every time they come in. So we don't have to start sizing, but sometimes things move because something has been shoved somewhere else. So we do need to be careful about that. And then of course, full monitoring every time we are heading in that situation. So we're looking at visible chest rise with each breath that we are delivering. If we are not, then we need to reposition, ensure that we are holding the airway open further, whether we need to do further more jaw thrust or chin lift, or try to use a two-hand technique if there's a huge amount of leak. And it's always useful to have an end-tidal CO2 connected to the bagging circuit so that you can see whether or not you're delivering the breath to the patient. Of course, we are always focused on oxygen saturation that the child should always have, and the heart rate and blood pressure, and the patient's responsiveness. Now, if you've got a responsive patient who has got some spontaneous breaths, then you are trying to just hold the bagging circuit with some PEEP and let the patient do their own breathing. That sometimes might be enough. So again, you can't do that with an ambu bag. You can only do that with a bagging circuit, right? Because the ambu bag, if you're just holding it on the face, doesn't even give an airflow. So we always have to be careful, because sometimes in an emergency situation, we forget. And we'd have the mask attached and we're holding the bagging, the circuit, the mask on the patient's face. And there's they're doing their own breathing, but there's no flow coming.
We had a critical event in Melbourne, so now all our bags have a big notice on them to remind people, because they accidentally suffocate.
Whilst that's why we use these bagging circuits. And as I said, they do require some experience. So if you're going to theatres, just holding the airway, just holding the bag and holding some PEEP is an extremely useful skill. As I said, you've already got expertise in nearly 90% of airway management if we know how to adequately keep the airway open, hold the bag, and deliver PEEP through that. So sometimes just the spontaneous breathing effort supplemented with that PEEP is good enough. Sometimes we would use it to transfer the patient to a more appropriate place. For example, if they're on HDU and I want them to be intubated here on PICU, I can hold the PEEP with the bag, and then I can bring them across. If the spontaneous effort is not adequate, then of course you do try to somehow synchronize with the patient's spontaneous efforts, which may or may not be always successful. So you do have to still keep in mind whether this child is too agitated and not getting enough oxygen flow, and at what stage we start thinking about giving them some anxiolytics or hypnotics. But we need to be very, very careful before we administer drugs, because we should be fully prepared for intubation if that is happening. And that could be also a temporizing measure before, if we think just giving some PEEP is enough for the patient, whether or not they would be sufficiently supported with some kind of non-invasive support, either with a with PEEP or high flow nasal cannula. So we look at that. And of course, we're looking at the patient's responsiveness. So this could be a child who's had some sedation and they're not fully awake yet, and then they're not breathing. And then with a bit of bagging, for example, a child who's seizing and they've had some benzodiazepines, and then they start becoming more responsive. So you would see the effort going on. So you can hold the PEEP and look at it. And that way you'd be also able to deliver oxygen, which you can't do with an amber bag. And then we're looking at the air entry and auscultation. So what next? We've tried all these things, and if none of these are effective enough, or this could also be a pre-intubation stabilization of the patient. Are we looking at intubation? If you're thinking about intubation, whether or not you would use a cuff tube or a non-cuff tube, what do you think? Yeah. So I think more or less as default, we would always use a cuff tube here in intensive care unless there's a specific reason.
But is that true for also smaller infants?
Yes. Yeah. And why would that be?
Avoid leaks.
Yeah. So I think, yes, mainly because we're worried about leaks. And if we can secure a decent sized ET tube with a cuff in the first attempt, and especially as the child's disease progresses, it might become more difficult to upsize the tube or change the tube. And if the ventilation is going to be harder, it would be even harder to then change the tube, and you'd not be able to deliver the right amount of pressure in the PEEP. So remember, in neonates, we don't like to use high PEEP because we're worried about the blood-brain barrier and the pressure transmission, retrograde pressure transmission. In neonates, term neonates and above, we're less worried about PEEP, and because the blood-brain barrier is now intact. So we do use quite high PEEPs, and having a cuff tube really helps, because otherwise you're leaking and you'll not be able to deliver what you want to. And people were worried about the edema, but I think now we've got soft microcuffs, so we can very safely manage them. And as I said, we do use post-extubation steroids. Again, we're thinking about intubation, so we're looking at what kind of tube we are putting, what size, what length, so we need to be aware of that. What drugs, if at all. So what is the situation where you'll not use any drugs?
Emergency.
Hmm?
Emergency, like the kid is flat, you need to get the airway done because.
So flat as in what do you mean by flat?
Completely GCS of 3.
Arrested.
Unconscious, arrested.
So I would say only in the situation where the patient is in cardiac arrest. I would not recommend a GCS3 to be intubated without drugs.
Okay.
You could, but you don't know why their GCS is 3, right? You also don't know what kind of reflexes they will have with the laryngeal maneuvering. And if they already have raised intracranial pressure, which is causing their GCS to be so low, that simple laryngeal blade insertion could be enough to cause herniation, because that could raise the intracranial pressure. So unless you're in cardiac arrest, I would say we should never try to intubate without drugs. So we'd always give drugs.
Like some of the shocks ones we don't use as much fentanyl.
Yes, so we could titrate the drug, the kind of drug we're using and the dosage we're using, but we should always use some kind of intubation induction drugs, and we'll come to that in a bit. What kind of fixation we're going to use, and I think more or less we use only one kind of fixation, and I think that's for later. I will not talk about what kind of ventilation settings we have to apply. We'll focus right now only on the airway. And we also need to then think about the intubation aids that we may or may not require. So of course, the laryngoscope and the blades that we would be using, whether you want to do direct or indirect laryngoscopy. Meggle's forceps, less useful if you're only doing an oral intubation, which is what we would do in emergency. And we might consider swapping it to a nasal tube once we've secured the oral airway, depending on, again, what the child has, in which case Meggle's is extremely useful. Stylets, of course, can be very, very useful, especially in younger children, because the smaller tubes can be quite flexible. And if you want to stiffen it a little bit with the stylet, it could help. Bougie, again, sometimes when the airway is difficult and you don't have a very good view, you can pass the bougie and then you can railroad the endotracheal tube over it. So sometimes we'd use that. Fiber optic scope, we have one on PICU. But I hope it never ever happens that you are being asked to use that, because we will always be here. And if it is an
just to save the boy from the appendix boy here.
Sure. Claire, do you want to ask them to attach monitoring and give us a shout if there's anything, or call Riaz? He's around. He knows. I've told him. Of course, the laryngeal mask airways and a potential of tracheostomy if required. Now, these are just the kind of things we should be aware of. Not necessarily that we would be preparing for each and every one of these every time we are intubating a patient. We are lucky because we are in a relatively closed environment, and we've got the trolleys and everything set up for us. So if we are in a situation where we have to intubate somebody in emergency, especially out of hours, and you're the only people on the floor, put out an arrest call or get the anesthetist if you have enough time. We should always have extra pair of hands. The normal practice would be, if you call me and say this child's not looking very good and I think this child is heading towards intubation, we will come in. One of us would always be there. If there's any anticipated difficulty with the airway, we would start thinking about whether we need the anesthetic backup or not, plus minus the ENT team if required. So we will always talk this through, and touch wood, we never reach a situation which is a completely unexpected airway complication that we did not anticipate. And if at all it is unexpected and we go ahead and we think this is all straightforward and the child should take the ET tube and it doesn't happen, thank the patient whilst we wait for the anesthetists and the ENT team to come. And that's why it's important to recognize the difficult pediatric airway. Of course, the easier ones are the syndromic children. You could see it, you would know exactly what it is. And sometimes we may not have in an emergency enough time to look or anticipate for that. We just have to go ahead. But if it looks like the child is syndromic and is likely to have difficult airway, it's probably a good idea because there are anesthetic registrars within the hospital. And the peds anesthetists are from home on call, so if we need to, we could call them as well. This is what the anesthetists use in terms of trying to identify airway difficulties, but they're doing this in an elective domain, and they're using what is called as a Malampati score, and essentially asking the patient to open their mouth wide. If they can see everything, including the soft palate, it's class 1, so straightforward, simple airway. Class 2 is complete visualization of the uvula, but they can't see the soft palate completely. 3 is only the base of uvula, and in 4, they don't see the soft palate at all. This is what you would see written in the patient's notes here, and this is the grading system we would define the patient's airway as, but this is only after the laryngoscopy. We cannot 100% be certain of what we would find till we put the laryngoscope. So it might be too late, but that might be the only option for us. So sometimes if the patient is a chronic patient or a frequent flyer or has been back from theater and is now not looking good, we would always say, oh, can somebody check what grade of airway they had? Because if they had a grade airway above grade 2, I would say I'd need an anesthetic backup, because I might be happy to have a go, but it would be useful to have somebody stand by, because if I can't get the tube in, then there is someone else who can do it. And then I would be more prepared to use the video laryngoscope, have the bougie ready, and be more prepared than a straightforward intubation.
Can I ask, where do you usually find this grade 3 and grade 4?
It could be, interestingly, it could be related to syndrome. It could be adenotonsillar hypertrophy. It could be just the fact that we made multiple attempts at intubating the child and they had a grade 1 airway, but the edema and the injury could lead to grade 3 and make it worse. And that's why the number of attempts at intubation are extremely important, because we don't want to keep going on and on, because we might just make a completely normal airway much worse. A lot of the times it's operator dependent, because they're not used to looking at pediatric airways. They haven't managed to get the tongue out of the way completely and they can't see anything. And we do have a lot of syndromic or tumor patients. It could be a compression from outside or from inside. The children who've got palate surgery, etc. So all of those children would fall in that category. Sometimes they could be a complex trauma patient. You can't move their neck, and if they've developed some swelling, or a burns patient, you could have a complex airway. I think
palate surgeries actually cause you problems, Shruti, given that it's like up here rather than at the...
Well, so it's interesting, but just because there's a lot of handling of the tissue, soft tissue, there could be a lot of edema, if you know what I mean.
Even further down. Yeah, sure.
Yeah. Not necessarily the actual site of surgery.
Yeah.
So that's like, is how we would define these. So ET tube, again, we talked about the cuffed and uncuffed, and traditionally people were worried about cuffed tubes because of the risk of subglottic stenosis, but we've come past that more than a decade back, and we're using it smaller and smaller. The smallest we have is a 2.5 ET tube size. I think the risk of aspiration is probably less important in terms of cuffed or uncuffed tube. And then, of course, there are all kinds of other tubes, which I'll not go into the details, but these are mainly in children who are undergoing specific kinds of surgeries. So the reinforced tubes have got a metal mesh in their wall. They are used in patients who are to be prone for the surgical procedure, like the spinal surgeries or the cranial surgeries, because when they're prone, the tubes are quite soft and they could kink, but the metal mesh makes sure that it doesn't kink when they're in a prone position. And these are long surgeries for 8 to 10 hours. And for us, it's crucial to know, because sometimes if the child has not managed to extubate in theater post a complex spinal surgery, when they come back intubated, we have to make sure that they still don't have a reinforced tube, because it's so stiff, the likelihood of an airway injury in longer term is bigger with that tube. So if the child requires ventilation on intensive care, we would change the tube, unless we think that in the next 2-3 hours we will be able to extubate this child. Again, important if the child then needs an MRI, because the reinforced tube should not go into the MRI, it's got metal in it. And most of the times the anesthetists would change it, but sometimes it's been so long and they might forget it. So we always ask them if they're telling us a question, and then they say, oh, the child would be extubated in the next 4 hours, they finally wait, etc. And then they would be double lumen tubes, kind of not that frequent in pediatrics, but essentially for single lung ventilation while they're operating on the opposite lung. And then the north or the south facing tube, depending upon the kind of airway or palate surgeries they would like to do. So they just bend all the way down. So that's just for the cleft repair. So the tube is kind of bent like that. It's almost a U-shaped tube. So that's a south facing tube. And then they also have a north facing tube, just to give access to the area that the surgeons want to operate at. I don't have a picture of it, but I'll show you. And these are just the way to define what kind of ET sizes we are looking at, both based upon the age and the weight, and what length at the lips and the nose we're looking at. What formula would you use?
The units it is different.
Twice, yeah. So you still need twice the weight plus you actually do it.
Yeah. How about
H on 4 plus 4?
Yeah.
And then you triple it to get the
there? Yes, absolutely. So it's just a rough number to know what kind of, like, if you don't have the child here in front of you and you just know their age, that's how you could do it. But then we can have a 10-year-old child could be as big as me and could be as small as 20 kilos. So it's sometimes difficult. So you do have to see the child. So always when we're calculating the ET tube size anticipated based upon the patient's age, it's always a good idea to have one size above and one size below. And then assess it once the child is here. And this has never failed me. The ring finger. So look at the patient's ring finger. Usually that's what they would take. So So yeah, so we size the ET tube appropriately and then look at the length. Well, in the ideal world, when you're inserting the tube, you would only insert up until the double black mark on the ET tube below the cord. So that's what you're looking at. And once you're past that, you don't need to keep going in further. And then how do we define whether we're going for nasal or oral intubation? Any ideas?
All the PQs debate over this a lot because they get all antsy about some of them, about the nasal, like.
But roughly, But roughly, what are the advantages and disadvantages of nasal versus oral intubation?
It's more physiological.
Nasal is more physiological.
Because that's when you normally take a breath from your nose out.
But you're bypassing the nose in any case because the air would be going through the tube, right? And you're ventilating somebody artificially in any case. So how does it make a difference? You might have some. You're on the right track, but the logic is not right.
Is it stable?
Yes, that's what you mean to say because it's anatomical.
Yeah.
And it has got some kind of a, what's the right word? It goes along the nose, so it's more stable, it moves less, unlike the oral tube, which is very easy to move up and down.
Follows the physiological curvature
of the airway. That's what you mean. Yes, absolutely. What else?
Sometimes they can, because of that, be a bit easier to get in, actually, I think. Like in neonates, I don't know, Eastern boys.
Don't do that, but it's like more probably user dependent, but it's easier, people say, those who does the nasal, that's easier and definitely.
Okay.
I haven't had any experience, so because we're so used to the oral, the direct and oral, it's.
What do you think, John? What might be the, why do we do oral tubes?
I think they're a bit faster, like because you'll manipulate, you have to sort of get the tube and then you have to pull it through with your gills.
It's fine. Yeah. You can sit. You can give your input.
No. Sure. But I was going to go talk to Isra's mum.
Okay. That's fine.
So I'll just give it.
Sure.
Thanks, Rhea.
The only thing I feel with the nose is easy. It's cartilage, isn't it? So it's easy to perforate, whereas we don't have anything.
Yeah. So you could have an injury to the cartilage. Yes, that's true.
So maneuvering could be sometimes difficult with the Maggie to get in and things that could be that.
Yeah. So for that reason, because it's quicker to get an oral tube, if you're in an emergency, you stick an oral tube first, right? If we don't have a controlled environment, which is majority of the times in intensive care, right? So oral intubation, yes, it's easier, it's faster, it's quicker. That's why we do it. The disadvantage could be because there's a lot of saliva, so that the tapes keep needing change constantly, as well as it's less stable in terms of the length. It can move quite a lot, while the nasal tube is a bit more stable. But equally, it's technically harder to insert. It takes longer time, and as you said, it could be cause injury to the nasal cartilage. Of course, because you're going through the turbinates and the adenoids, you could cause a lot of bleeding, and you might just completely lose the airway because and sometimes you literally feel like you've done an adenoidectomy just by pushing the tube in. So we have to be careful that knowing that the child is not coagulopathic, because they could bleed quite significantly, and imagine having blood in the airway and then trying to intubate a patient like that. So that's why the regular practice is to stick an oral tube first, and then if everything is calm and safe, and if we expect that the patient is going to be ventilated for longer, we would try to go for a nasal tube because it's easier for the patient to tolerate as well. We can deal with the patient a bit more awake rather than with the oral tube because they're not coughing and gagging on that. So the nasal tube is that way comfortable. but extremely important to rule out coagulopathy and basilar skull fracture, because you can place it inside the skull. So you don't want to do that. So any trauma patient and any kind of nasal tube is a no-no. So no nasogastric tube, no nasal ET tube. They would always have an oral gastric tube and esophageal probe for temperature and an oral tube always. And then as you said, there could be I think people went away from putting nasal tubes because there was some evidence of increased sinusitis following the prolonged nasal intubation. Of course, the cartilage damage. So every time, if you see, once you put the nasal tube, you have to look at the nares. And if they're looking white and blanched, you know that the tube is too big. And you have to think whether you could either insert a smaller tube or whether the nasal tube is really warranted. And again, the positioning is extremely important. So any kind of traction on this cartilage is going to cause it more damage and pressure sore. So it has to be south facing like that. So when you're taping it, you have to ensure that it's facing downwards, not facing upwards. Because sometimes just with the pressure and the pull of the ventilator tubing, etc., could go up. So every time you walk to the bedside and see that, just bring it down, make sure that the tube is facing downwards. So that's why we are careful. And I know John raised a very valid point in terms of the ongoing debate within intensive care world. And some units would like to put nasal tubes in all their patients because the sedation requirements are less in comparison to oral tubes, because as I said, they're more comfortable and they're a bit more stable. Equally, if we are looking at our median lengths of stay, especially for the bronchs, etc., it's between 4 to 5 days. So how much of a gain it is, and whether or not you might be causing some degree of harm. The other argument could be because you're doing it so often that everybody is skilled and you're doing it more smoothly than doing it occasionally. So you might be more deft at getting a nasal tube in. So we use a combination. Our default here is still an oral and ET tube. And it's technically challenging in a small child, because if you try to think about that mouth, which is small, you've got a laryngoscope, you've got an oral tube going in, you've put a nasal tube hanging at the back, and then you're putting your muggles in to try to hold the nasal tube. And the ideal way you swap the oral tube to the nasal tube is leave the oral tube. The advantage is you can still oxygenate the patient with that tube. Somebody's bagging that patient with the oral tube, and then you stick the nasal tube in, and then you push it down. You see it at the back of the throat with the laryngoscope. You put the muggles in, and then you bring it as close to the vocal cords as you can, and then you ask someone else to pull out the oral tube and you slip it in. So that would be the smoothest way to do it, causing least disruption to the oxygenation, especially in a child who's got oxygenation problems. If the child is otherwise stable, you might still be able to take out the oral tube and then stick it in. And it's not uncommon that you lose the view of the airway. However nicely you might have held it, but just the sheer force with which the oral tube is pulled is enough. So you might have to readjust your laryngoscope a bit better. But the biggest marker of success in nasal intubation is how well you can view it. And then we also have to be careful, because we use cuff tubes, that it's very easy in the heat of the moment that you might use the Meggles forceps holding the tube here. And then because these are micro cuffs, you could damage the cuff. And then you've inserted it, but then the cuff is leaky because it's damaged. So it is very, very important that we're holding the tube with Meggles up here rather than down there. Yeah. So it's probably easier if you've got an older child. It's a bit more challenging in a younger child, in infants specifically. Just very briefly about the LMAs, and I'm not sure if you've ever used LMAs in your practice so far in neonates, but essentially these are supraglottic devices, and they are extremely handy, especially if we cannot get the ET tube in and if the view is really bad. Sometimes it might be easy to ventilate and oxygenate the child whilst we're waiting for more help to arrive by just sticking a supraglottic airway. And these are in fact, being used more and more. And I'm not sure, John, if you've had anyone using it in the panda transport, but I do know that in cats, some of the children have also been transported with the
We moved one baby from South End to like few years, maybe a year back with a LMA because the airway was not being able to. So ultimately, we put cats came as well.
Yeah.
But then it was ants actually, ants and cats together.
Yeah.
But it helps straight away.
Yeah. But again, it's not a secure airway, so we have to be careful, and especially in a transport kind of setting, because you do want a definitive airway. You don't want to be in a situation, especially if somebody's got a complex airway. You don't want to have to deal with it in the back of an ambulance. You'd rather do it at the base hospital before moving the patient, where you can get anesthetists and other help if required. So again, like, straightforward, you just lubricate it, stick it in, let it bounce back where it sits, and then you can bag it. You put the cuff up. And a lot of the easier, shorter surgeries are done with LMA because the recovery time is quicker and you're not going through the airway. So potentially you're avoiding any kind of discomfort that the patient might have. So that's not an uncommon practice. So if you go to theaters here and certain lists you would go to, you might just get to put LMA, but it's a good experience still. As I said, it would still give you, because you're holding the patient, bagging them, just to be able to hold the bag and know what size of patient you would hold the bag and what kind of pressure you would need to use. So that's a useful exercise. The pack would say what weight it would go up to. So it's easy to pick out if there is no other way you can oxygenate the patient. And this is how it would sit, right? And you can even stick a catheter in and do some suction if required. So it's a good device. Coming to laryngoscope blades, well, we've got two different kinds, the straight blades and the curved blades. Straight blades probably are more used to coming from the neonates, which are easy because, as we saw earlier, the epiglottis is quite big and U-shaped. So the straight blades are good to get the epiglottis out of the way. And also given the anatomy of the infant skull, they're probably easier to use. Whilst anywhere coming up to about 1 year of age, a curved blade might be more useful. So the straight blades are placed under the epiglottis and used to lift anteriorly to expose the cords, while the curved blades are placed in the vallecula, so that is just before the epiglottis to slowly pull the epiglottis away from the vocal cords. These are the commonest ones we have are the Miller and the Mac blades. And I just put this up. This is called the Robert Shaw blade. I like that because the current lot we have, which are disposable laryngoscope blades, the straight blades are just too curved. And I certainly find it harder to view it properly because the curve is quite acute angled. And you've got two sizes in the Miller and then, of course, the 3 sizes in the Mac blade. So the Robert Shaw is quite useful because it's got a slightly wider blade. So to get hold of the tongue, it's much easier. And it's a straight blade. And these are just as a rough marker in terms of what kind of blades we would be using. So probably a Miller 0 till about 1 to 2 months of age. And then beyond that, we're using a Miller 1 or a 2. And then the Mac blades size 2 or 3 for the older kids. I think this just appeared here at the wrong place, but just gives an idea of how we could also use a head circumference with in terms of trying to interpret the ET tube length. But of course, the best way is to insert it till you see the double mark on the ET tube and then wait for the chest X-ray. But it is not uncommon for all of us to insert it too far in because we're so excited that we've managed to get it in. And then especially if things are not going as per plan and you have had some difficulty in oxygenating, you do want to push it in. And so we always do a chest X-ray after that. So it's less relevant to us. It probably is more relevant in theater setting because they intubate the patient and they're not doing an immediate chest X-ray. This is again just another chart, and these are the slides there from Rosalie's presentations. As you can see, I have stolen them, and that's why they've appeared at the wrong place.
Oh, the other thing that one of the ODPs told me the other day was cutting the tapes. He said, I always look at the size of the wrapper for the ET, and he cuts them to the same length.
That's a good one. I've never thought of that.
So that was quite
You
good.
look at the
For the Melbourne strapping.
Yeah.
Because you know how you do two Ys.
I'll come to that as well.
Yeah, so that when you cut the tape, you look at the size of the wrapper for the ET tube and you cut the tape the same length.
That's a good way.
Yeah.
Never seen that. So, so we're kind of trying to intubate a patient. So what are we trying to get ready? Of course, the suction equipment, yankers, catheters, the right kind of tubings. And again, as I said, if we're intubating on PICU, I feel I'm in my comfort zone because everything is already ready on each bed space. Whilst if you're in ED, you have to ensure that you have a working suction before you start launching into giving drugs and intubating somebody. So it's an important idea to have all the equipment ready. So suction equipment, oxygen, of course, the flow meter, if we can pre-oxygenate the patient with bag valve mask. And hopefully we have a right-sized bag valve mask at that stage. This is how you would connect the end-tidal CO2 with the bag valve mask circuit. And you should be able to see, of course, you have the right laryngoscope, the right size blade. Always useful to have one or two extra sizes in there, especially if you're not entirely sure if the size you're using is the right size, because you should be able to have it at hand so that you can change the blade if required. We have an airway trolley, which will come equipped with everything. We also try and take out the airway, size it appropriately in case we needed it, and of course the right size DT tube. As I said, a size above and below. And then lubricating gel if required, and specifically if you're doing a nasal tube. So again, that's a matter of personal preference. I certainly don't like lubricating the tubes if I'm doing an oral tube because it just makes it messier. But you definitely need that if you're putting a nasal tube, and you put a lot of lubricant, especially because you're going into the nose to try and make it smoother. You have to position the bed, position the patient, position the personnel, make sure there are two people present who can intubate the patient. And we have the right rules for positioning and the height of the bed, which are all equally important. Sometimes you also have to worry about giving it over to the next person, and there could be a huge height difference, like John and me, if we're trying to do it. So you have to be prepared with the bed height. We do have to have full monitoring. Ideally, we start the monitor on a beeping sound so that I can know what is happening if the patient's going bradycardic even without looking at the monitor. We cycle the blood pressure on every 3 to 5 minutes so that we know what the effect of our drugs are. Sometimes, especially those who have some kind of hemodynamic instability, or even if they don't have any hemodynamic instability, they're otherwise managing the hemodynamics. The moment you give them induction drugs, the blood pressure drops. So you have to be careful in such patients that you're prepared for that kind of hemodynamic compromise, with having IV fluids ready if required, having some kind of inotrope ready if required. In older children, you could possibly use metrominol as a bolus, and in younger children, we'd probably have adrenaline infusion or a syringe ready in case we needed to use it. And then, of course, as I said, always think about the stomach and make sure that we have decompressed it, have an NG tube ready. It sometimes makes it harder to have the right seal with the mask, but it's an extremely important piece of kit, because if the stomach gets inflated, you'll not be able to bag the patient. You would start having hypoxia and deoxygenation very, very rapidly. And the end-tidal CO2 detector. Of course, we should not forget IV access. In the ideal world, you would want 2 working IV access, one for the drugs, for induction, and the other for resuscitation if required. And we do also always have to anticipate if things don't go to the plan, who else is available, who should be informed. even if things are completely straightforward, it's always a good idea to let the nurse in charge know that we are going to intubate in this bed space, so that in case patient goes into cardiac arrest, who knows what happens. We have to be prepared for the worst outcomes. So always make sure that the public around you is aware of what is going on. Very briefly, the anesthetic drugs in pediatric emergencies, well, of course, oxygen comes first and foremost. Volatile agents are for theaters. We're not going to talk about that. Sedative and induction agents is what we would use when we're intubating patients. Muscle relaxants, support drugs, as I spoke about. I certainly use atropine in younger infants, definitely under 6 months old, because they have a very strong vagal reflex. So the moment you touch their larynx, they tend to have bradycardia. And because their cardiac output is very dependent on the heart rate, they could dip very, very quickly. So the time you have for that is very minimal. So if you give atropine, the heart rate stays up. And you're likely to keep a good cardiac output. You have a little bit more time in terms of maneuvering the larynx if required. It's not a must, but again, personal preference. I don't know what Riaz does, but I would certainly ask for atropine.
Oh yeah, I mean these guys told us no.
Yeah,
you whiff the larynx and they go ready.
Yeah, adrenaline, as I said, if required, and metronidazole, you'll probably see it being used occasionally in PICU, and then skilled personnel and equipment. Hopefully, we'll have that ready. The main anesthetic group of drugs that we use intravenous induction agents. The inhalational are again for theater. They're important for us to be aware of because there are situations, again, especially when you're anticipating a difficulty with the airway, whether or not it would be safer to use inhalational anesthesia for intubation rather than IV drugs.
Just to let you know, we are retaking so if we holler.
Thank you.
That's fine.
Because the IV induction agents cause more hemodynamic compromise in comparison to inhalational anesthetic drugs.
So IV causes more
hemodynamic compromise in comparison to inhalational. But equally, for inhalational, you'll need to organize an anesthetic trip to theater. And if you're doing it in emergency, we may not have time. And then, of course, the neuromuscular blocking drugs. And then what we're going to use after the patient is intubated for maintenance.
Is any of our consultant group now okay with doing inhalational?
No.
Yeah.
So we did have a machine which was only operated by Rosalie because none of us are allowed to touch it. We had an anesthetic machine here, but we now don't have an anesthetic consultant in our group, so we're not using it anymore. As I said, depending upon the patient's condition and how quickly we need to do things between IV or gas, we need to think about. So IV, rapid onset, of course, we need IV access. It will not cause any coughing or laryngospasm because you've hopefully taken that away. They will tolerate the adjuncts better, whilst with gas inhalational anesthetic, they'll be intolerant to Goodell's. There's increased risk of vomiting with gas induction in comparison to the IV. And of course, with the IV, the airway is vulnerable with gas. The advantage is that you could still have a patient very deep whilst they're still breathing. So it's easier to manage the patient and you have a bit more control in terms of how you go ahead. Whilst once I have given a paralyzing agent, I've completely lost the airway, the breathing reflex, and then not the reflex, but the capacity to breathe. And if I can't intubate the patient, then I run the risk of cardiac arrest if I don't work quickly. So majority of the hypnotic agents, so to say, used for induction, and I know our pediatric practice is very different, are these three. And they are usually lipid soluble so that they penetrate the blood-brain barrier and achieve a high concentration because that's where you want them to act. So the commonest one used are propofol, etomidate, and thiopentol. I would say we should forget about etomidate and thiopentol because we don't use it at all. we would use propofol, and we sometimes use ketamine depending on what the patient has. In theory, you could just intubate using the hypnotic agent along with a paralyzing agent, but usually we would use an opiate for analgesia. That's why the fentanyl in a very small baby, we might consider using morphine, especially if you're worried about chest wall rigidity with fentanyl. And in our setting, we're doing a rapid sequence intubation, especially in an emergency situation where the patient may or may not be fasted. So we have to be aware of the risk of aspiration, vomiting, and we do use crack wet pressure to try and limit that. So in RSI, we do have to consider limiting the bag valve mask ventilation as much as possible. We still want to oxygenate the patient, but the longer you bag and valve the patient, the higher the risk of vomiting and aspiration. So we usually try to, that's why it's called rapid. So everything has to be rapid IV injections and crack wet pressure to limit the aspiration. And just as a brief outline, maybe you could leave the thiopentone in the middle, but look at the propofol and ketamine, which are the commonest used drugs here. The half-lives are different. The volume of distribution is different. The most important factor to look at is the effect of the drugs on the blood pressure and the cardiac output. As you see, propofol has far more profound effect in comparison to ketamine. And that's where you might consider using ketamine over propofol, especially if the patient is hemodynamically unstable. Saying that does not mean that ketamine cannot cause hemodynamic compromise, but ketamine is essentially a sympathetic stimulant. But if the patient's already so stimulated and the heart rate is very high in a hemodynamically compromised state, like severe shock, you might still be able to drop the blood pressure because there's no more sympathetic drive to keep the blood pressure up with ketamine. Equally, very, very rarely you could cause hypertension with using ketamine because of the sympathetic stimulation. And that was the key reason people did not use it for patients with raised intracranial pressure, because they were worried that it could cause further raised intracranial pressure. But there's sufficient data now, and in fact, it's the drug of choice in pre-hospital intubations for trauma or anything else, for the main reason that it is amongst all the bad drugs, it's probably the best drug in keeping the hemodynamic stability. And in a patient who's got head injury, you want them to have decent cerebral blood pressure, blood flow, and you don't want them to become hypertensive. So it's almost the drug of default for pre-hospital intubations. Yes. And we do use it sometimes here on PICU. You could, in theory, use any drug, provided you know how to use it. You just have to titrate the dosage to a lower dose. So if a patient is in septic shock, you don't use the same dose of propofol as you would otherwise use in a child who's otherwise stable. So that's just something to be aware of. But we would commonly use either propofol or ketamine. And thiopentone is not used by us at all. It's a drug always talked about, especially when you have got a child who's fitting, because it's an anti-seizure drug, and sometimes people use it as an induction. I certainly don't use it, right, because we have very limited experience, and given the wide range of patients we intubate, it's always a good idea to stick to one or two drugs that you know well, rather than trying to use all kinds of different drugs. And that might be an anesthetic skill, because that's what they specialize in for us. It's best to stick to one or two. And if you had to choose between propofol and ketamine and you only wanted to use one, I'd say ketamine over propofol. Just very briefly, like, the combination of a hypnotic with the neuromuscular blockade, the pros and cons of the different drugs. So when we're talking about neuromuscular blockers, we're looking at either the depolarizing or the non-depolarizing agents. We did use succinylcholine quite a lot because it's one rapid onset and it wears off quite quickly. So it's easier to use, because if you can't intubate the patient, at least the patient's breathing effort would come back because it'll wear off quickly. Whilst if you'd used vecuronium or atracurium, the effect would last much longer. And if I fail to intubate, then the patient would not still be able to breathe for themselves. But now we've got rocuronium, which has got a quicker onset of action and quicker reversal as well. So we have more or less switched over to rocuronium because succinylcholine can sometimes cause fasciculation and hypokalemia. So it's less commonly used. And there are certain neuromuscular conditions where you would not like to use succinylcholine. So our default mode has moved from sucks to rock. If you're very comfortable, you've intubated the patient earlier and you think that you'd be able to get in, by all means, if they have the VEC floating around, use it, but that's not recommended. But I'm saying that just because sometimes you would see that happen here, but that is only because people are very comfortable with using it. As I said, we'd normally not say that opioids and benzodiazepines are good induction agents, but we would use a small amount of fentanyl. And this is what the anesthetist would believe in. But if you see a patient who's hemodynamically extremely compromised for a cardiac issue or peri-ECMO, they would probably be just using fentanyl and nothing else in that age group. And benzodiazepines are, again, certainly not a reliable induction agent. Neither is morphine, because they take far longer to act and thereby not recommended for use. Just another little chart, I can send it to you to revise in terms of the hemodynamic effects with different kinds of drugs. And if we focused on these, which are the commonest used, we have, it's sort of just a useful reminder of what we use and why we use them. Muscle relaxant, as I said, the choice between depolarizing and non-depolarizing. And then this was traditionally what we thought. The non-depolarizing was slower to act. And then the speed of offset was slower as well. And that's why till fairly recently, I would also use as a default sucks, unless I was in one of those situations, which I just described. And the downside of depolarizing was that we couldn't reverse it by any means, whilst we had the reversal agents for non-depolarizing. So that's that. Now, I'm very aware that I've been going on for quite a long time. So I'll not go into the details of these, but there is in the intensive care medicine, only this week, there's an article talking about intubations in critical care. And they've got a very nice algorithm in terms of how we should go about doing it. So if you look at it, 2 operators, metal blades, and this is for adults, and rapid sequence is mandatory. We do, as I said, think about difficulty of intubation and then prepare accordingly whether or not I need more help. Now, this is a scoring method based upon the Mallampati score as well as the experience of the operator. And depending on where they fit it, you could decide whether you need more expert operator, i.e. an anesthetist plus minus an ENT surgeon, if you're really expecting badness, whether or not ICU would be the right place to intubate. Both. You have, depends on both, whether you have enough time to send the patient to theatre, etc.
I'm interested they put the metal blade in, given so many places are going to these throwaway plastic video laryngoscopes.
Yeah. Well, we do have this. So the CMAX have blades which are reusable. They're metal blades as well. And then depending upon the anticipated difficulty, well, sometimes, like, you can easily make a grade 3 into a grade 2 or a grade 2 into grade 1 just by using the video laryngoscopy. And it's quite fascinating to, like,
we have started using it for the last 12 years. And it's really sometimes become easier.
Yeah, and it's just like you put the laryngoscope and you see nothing, and then you put the video, you put the CMAC, and suddenly you're like, wow, I can see everything. It's just literally like, something changes completely.
I have struggled, to be honest, with the video.
You need a little bit of hand-to-eye coordination because they look that way and do this. So
it takes, because you're so used to seeing this way, and suddenly this takes a bit of time.
And then if we fail, always remember what is most important is oxygenation. So intubation failure does not matter so far as you can oxygenate. Just oxygenate. Do not go back to attempting further intubations. Wait for an expert to come if we've failed or if there's an anticipated problem. This is just, I put this scoring method, which I found quite interesting. I've never seen this being used in pediatrics, so I won't recommend it, but just knowing what they look for. So if there is like, a difficult airway, anticipated obstructive sleep apnea, C-spine limited, etc. And then of course we have to have more than just a plan A. So if we fail, what are we going to do? Have a plan B, which will be again oxygenation with a supraglottic airway device, and then we declare failed intubation after 3 maximum attempts, right? And if we are failing with that as well, we then say we use either a fiber optic intubation or something else to do, and call for help at every stage. And then there is plan C, which is pure face mask ventilation if you can't even oxygenate the patient with the supraglottic device. And then plan D, which is can't intubate, can't ventilate situation, where you go in the front of the neck axis. Hopefully you would never ever have that situation all on your own, because help is always here, and always, 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 always ask for help. Whether it's an emergency intubation or otherwise, we do not allow anyone to do that without one of us being present here, or an anesthetic registrar being here if we can't reach here in time.
Use Sugammadex here?
Very rarely. That's more a theatre drug, but that's the reversal agent you would use if you're struggling. But we are good at anticipating where things would go completely pear-shaped, and we would call for help earlier rather than later, and have a lower threshold to ask for an anesthetist to be either here, and if we have time, to send the patient to theatre with the ENT consultant present in case we needed to do a tracheostomy in emergency. And of course, post-intubation, we always ensure the entitled CO2 assessment, auscultate, and then secure the ET, do a chest X-ray to confirm, and then put the patient. So this is probably what you're used to using in neonates.
Yes.
Yeah. But this is what we do here on PICU. So we call it as a Melbourne strapping method from John's unit, and essentially it's trouser legs. So you've got, this is an unsplit part. You stick it on one side, and then there are trouser leg. One bit of the leg goes on the top, the other one goes around the tube, and then the other bit of the tape comes from this side, and then the lower one goes either on the upper lip, depending on whether you're taping the oral or the, you would have seen it in every patient. So this is what we use, and it is secure. As I said, so mentioning the nasal tube has to be facing like that. You don't want it to be facing.
And I think the other thing would be different to neonates. We would normally put the tube on the side, whereas you guys would have it in the middle, right?
Yeah.
Yeah, so we have it on the side so the nurses can do mouth care.
Okay.
Yeah, because I didn't know that till after one.
Yeah. If you have acute deterioration post-intubation, we'll of course think about the whether it's displaced, it's flipped out of the trachea and gone into the esophagus, whether you have placed it in the esophagus by mistake and it hasn't been recognized, whether it's obstructed because there's thick secretions, pneumothorax, or the equipment failure. So always think about that. And then we do a chest X-ray to avoid this, which is one-sided. So that's the right main bronchus intubation, too far. And then just as the last couple of minutes, always very important to think about the dead space and the resistance, because there are, as I said, we've got a size range from 2 kilos to 120 kilos. And if we're using the wrong equipment for the wrong size child, we could create a huge resistance and not be able to ventilate the patient appropriately. And that comes mainly surrounding the catheter mounts, the extensions that we would use between the ET tube and the ventilator tubing, the humidifications and the filters that are used. So if you look at it, the dead space between a neonatal filter and an adult filter is huge. It's like nearly 10 times more. And in the context of the amount of tidal volume you're delivering, it can make a huge difference, right? So it's extremely important to get rid of these. When we're looking at a child who's being intubated for neurointensive care and needs appropriate CO2 management for cerebral circulation, you may not get the right CO2 levels just because you have added a connector which is wrong. So extremely important if we are struggling to clear CO2s, your ET tube is in the right position, there's no secretion, and the chest x-ray looks like it's just normal lungs. Always think about whether we've got one of these wrong. If you extend, so there are these compressible extension cords. If you extend them, the volume would be 80 mils. Imagine trying to ventilate a 6 kilo infant with an 80 mil of that space. So that could be huge. So we have to be careful and think about these. Again, these are the various different connectors where you have dead spaces, which would vary quite a lot. And we also have different end-tidal CO2 connectors. Again, they have different dead spaces depending upon the needs. Yeah. So important to think about that. Of course, as I said, just as a summarizing pre-intubation, be very well prepared, think about difficulties that could happen, call for help, always have the consultant around. We will be here, we'll not leave you alone. If the consultant's not there, call theaters, get the anesthetist to come here. Per intubation, we follow the steps and the checklists which are available post-intubation. Of course, make sure that tube is in the right position, we secure it appropriately and manage the patient appropriately. I'll not talk about these, but there are lots of algorithms available on the Pediatric Anesthesia Society website for UK. Definitely worth looking at. The guidelines are there in the folder as well. This is I brought the folder.
When does it stay?
The PICU. But look at the algorithms as to basic algorithm for extubation, for difficult extubation, what we are thinking about, and you'll see that practically here as well. Every time we got a slightly more complex child, how we plan the extubation and how we prepare in case that fails. And then there are difficult intubation guidelines, as well as the guidelines for cannot ventilate, cannot intubate for children as to how we go along doing that. So thank you very much. That is all I had to